Hey guys, Dr. Carmen Bryant here with NursingSchool911.net, and I'm doing a video by request today. So this video is going to cover a few things about cardiac assessment. So we're going to talk about the blood flow through the heart. We're going to talk about the normal heart sounds, which are S1 and S2. We're going to talk about abnormal heart sounds, including S3 and S4. And then we're going to touch on murmurs. So let's go ahead and get started. I've got a lovely diagram here drawn that looks exactly like your human heart. So I've got the right side represented over here, and you see it's in blue. That's because you have all unoxygenated blood over here on the right side. And then the left side is our powerhouse of the heart, and it's carrying the oxygenated blood. So blood returns to the right side of the heart from the superior and inferior vena cava, with those labeled here. So it brings that unoxygenated blood into the right atrium, right atrium. Then it flows through our first valve, which is the tricuspid valve. I've got that abbreviated TV and drawn here with its 3 leaflets. So then it flows through the tricuspid valve down to the right ventricle. Then from the right ventricle, we enter the pulmonary valve, or the pulmonic valve here, and the blood enters the pulmonary artery, abbreviated PA. All right, so our pulmonary artery, one of the only arteries that carries unoxygenated blood, right? Arteries carry oxygenated blood, not the pulmonary artery. So it carries unoxygenated blood off to the lungs to get oxygenated, and then that oxygenated blood is brought back by the pulmonary veins into the left atrium. So we have red oxygenated blood being brought back into the left atrium by the pulmonary veins. That blood then flows through our only normally bicuspid valve or mitral valve down from the left atrium into the left ventricle. There's our mitral valve. And then from the left ventricle, it's going to flow into the aortic valve, which is normally tricuspid as well. The only valve that is supposed to have 2 leaflets is the mitral valve. So it flows into the aortic valve, and it is carried off to the body by the aorta, okay? So real quick recap on blood flow through the heart. So let's talk about heart sounds. So S1 and S2, those are our normal heart sounds, right? That's the lub-dub that you hear in a normal, healthy patient, okay? What makes those sounds? So those sounds are produced by closure of valves, all right? So S1, that sound is produced by the simultaneous closure of the mitral valve and tricuspid valve, okay? Those are the valves that are in between the atria and the ventricles. When those valves close, then that marks the beginning of systole, okay? So those valves close, mitral valve, tricuspid valves close, S1 is produced. That marks the beginning of systole, where blood is pumped out through the pulmonary valve to the lungs and out through the aortic valve to the body. So when blood is being pumped out through the pulmonary valve and the aortic valve, that's systole, okay? So S2 then is marked by closure of your pulmonic valve and your aortic valve. Boom, when those close, that produces your S2 sound, and that marks the beginning of diastole. So diastole is the time period where blood is kind of passively flowing and kind of being forced down from the right atrium and the left atrium down into the ventricles. So blood is flowing through open mitral and tricuspid valves down from the atria into the ventricles. Okay, so those are our normal heart sounds that you're going to hear, and what produces those sounds, and what's occurring, you know, as far as systole versus diastole when those valves are open versus when they're closed. Now let's think about those abnormal heart sounds that you're not supposed to hear in a healthy patient, but unfortunately not anybody in the hospital that we're taking care of is healthy, right? Because they're there for a reason. So two of those abnormal sounds are our S3 and our S4. So S3, probably one of the more common heart sounds that you're going to, run across. And I will tell y'all, do not beat yourselves up if you're not able to easily identify an S3 and an S4. They're very, very difficult to identify clinically. But we'll just talk about the theory behind them and the pathophysiology that produces these abnormal heart sounds. So I want to say, S3 is actually heard immediately after S2. So you'll hear your normal lub-dub, but kind of like a lub-dub-dub, lub-dub-dub. Okay, so it's immediately after S2. And that is your S3. That occurs in early diastole, because remember, S2 marks the beginning of diastole, okay? And so what's happening in an S3 situation, what's producing that, is that there's a ton of volume being kind of forced down into that left ventricle. And you're hearing that volume kind of cause your mitral valve to do some funny things, okay? So when we think of these, the S1, the S2, the S3, the S4, they're all produced by what the valves are doing as far as closing and things. Okay, so when you've got a ton of volume, CHF, let's say thyroid storm, when the heart is just being really overworked or whatever, but mainly CHF, congestive heart failure, volume overload. You have a ton of volume being forced down from that left atrium into that left ventricle. It will produce that lub-dub-dub, that extra heart sound, that S3 that you hear immediately following S2. So that typically always marks a volume overload, a pathologic sound. I will say that, in NCLEX world, in the land of standardized exams and things like that, you will hear about what's called a physiologic S3. And a physiologic S3 can be found in young adults, younger than 40, or a very well-trained athlete where their ventricles are very supple, they're very well conditioned to accept large amounts of volume. They become conditioned to larger cardiac outputs. And sometimes you'll hear a physiologic S3 in that population. So younger adults, very well-trained athletes. All right, now I want to ask you, how many extremely well-trained athletes have you taken care of in the hospital? Not many, okay? So when we're thinking about who we're taking care of in the hospital, as far as our sick patients, our cardiac patients, hypertension, CAD, the diabetes, all that, our S3, we're always going to consider it pathologic, okay? I also want to mention that any of these abnormal or funky heart sounds are best heard with the bell of the stethoscope, okay? So we're going to use the bell as opposed to the diaphragm. This is our bell, and we're going to listen at the apex of the heart. So the apex of the heart is at the bottom, all right? So literally, typically the left ventricular apex is where you're best going to hear that sound, and kind of having the patient kind of on their left side, you'll really hear that sound best, So the best thing that we can do when we've got a patient that's in congestive heart failure and they're struggling to breathe, right, is like, okay, sir, I need you to turn over this way with, your left side so I can really listen to that apex of your heart. No, probably not going to do that, okay? But when you're taking your exams, NCLEX, standardized exams, test, whatever, apex, left ventricular apex, left lateral recumbent kind of position with the bell of the scope. Now, another abnormal heart sound that I want to mention is the S4. So this one is heard immediately before S1. So it is very late in diastole, okay? So S3 is heard in early diastole, whereas S4 is heard in late diastole. So it would be more of like a lub-dub-dub, lub-dub-dub, lub-dub-dub. So kind of like more of a split S1. But a split S1 is something totally different. Okay, that's a totally different thing. But you're going to hear that S4 immediately before S1. And what an S4 represents, and it is always pathologic. There is never any circumstance where an S4 is a good thing. So when you would hear an S4 is in patients that have things like left ventricular hypertrophy. They have a very stiff ventricle that is non-compliant and does not want to accept large amounts of volume, okay? So you have a left ventricle that's like, like I'm stiff, I am scarred, I'm hypertrophied, there's no room in here, okay? So it's gonna be non-compliant, in other words, to accept that large amount of volume, like in our, fluid overload patients, in our thyroid storm patients, or thyrotoxicosis, however you want to phrase it. So that's when you would hear an S4, very late in diastole, just before S1. Okay, so that is just an overview of those two abnormal heart sounds. Again, both of those best heard: bell, left ventricular apex of the heart, left lateral recumbent position. All right, so I'm going to actually call on my husband, Greg, to come over here, and we're going to talk about murmurs. So murmurs are created. They're a lot easier to hear, y'all, than an S3 and an S4, but murmurs are created when there is a bunch of turbulent blood flow over the valves, okay? And the main murmurs that you're going to hear produced are produced when there is disease of the mitral valve or disease of the aortic valve. These two valves incur the most disease because guess why? They're on that left side of the heart. The left side of the heart is the powerhouse of the heart that's pumping out to the body, okay? And so that side of the heart gets overworked and it gets the short end of the stick when it comes to valvular diseases. So when you're taught to listen, I don't know if you remember, if you're taught 8 to man or however you're taught to listen when you're, assessing your patient's heart sounds. But I'm not going to put these in my ear because I don't want to be able to hear myself talk. But you're listening where that valve sends blood, okay? So if you're thinking about anatomically here, I listen very close to the sternal border. So you're thinking this is the aortic area, all right? So this is where you would put your scope to listen to the aortic area. Think about that aortic valve. It's pumping out to the body. This is where the aortic valve sends its blood, okay? So if you're listening for a murmur of aortic stenosis or aortic regurg, you're gonna hear it best here, okay? Then the pulmonic right here, tricuspid somewhere around in here, and then the mitral area over here. So if you're listening for a mitral stenosis or a mitral regurg murmur, then this is where you would listen, okay? So you would go, A, P, T, M. And, unfortunately in our ladies, yes, we do have to, move anatomy out of the way to get a better sound. And if we've identified that, yes, there's a murmur, again, use that bell of your stethoscope to best auscultate that murmur, okay? So one more time: aortic, pulmonic, tricuspid, mitral. This area is also what we're going to call the apex. This is the PMI. This is the point of maximal impulse. This is where you would look for that apical impulse. If you were to visibly see an apical impulse, you would see that at the PMI. And sometimes you can actually see that, and it's not even abnormal. In somebody that's super thin or something like that, you can actually see the heartbeat in that PMI. Now, in somebody that's obese, you're not going to see it. Okay, so you wouldn't see it in Greg. Just kidding. Thank you. All right, so that's where you are going to listen. I just lost my earring, y'all. So let's talk about these murmurs and what produces these. So I have aortic stenosis, aortic regurg, mitral stenosis, mitral regurg. These abnormalities within the valves cause murmurs to be auscultated. So, stenosis. This is a valve that is supposed to be open, but it's stenotic. It's closed, okay? So remember, stenosis is when a valve is supposed to be open. Regurg or regurgitation is when the valve is supposed to be closed, but it's flopping back open and allowing for regurgitation or backflow of blood. Okay, either one of these issues is going to cause a murmur to be heard. I might as well go ahead and take out my other earring, right? I'm getting rowdy talking about these murmurs. So aortic stenosis, let's start with this one. So a murmur of aortic stenosis we know is produced when the aortic valve is supposed to be open. Stenosis, it's supposed to be open. When is the aortic valve supposed to be open? Well, it's supposed to be open in systole. Okay, aortic valve is supposed to be open during systole. That's when blood is being pumped out to the body, being pumped to the lungs. So a murmur of aortic stenosis would be a systolic murmur. Okay, so you would hear this murmur throughout systole typically. And aortic stenosis, it affects like elderly women, mainly due to calcification on that valve. Okay, so aortic stenosis is a systolic murmur. All right, aortic regurgitation. So let's look at regurgitation. This happens when the valve is supposed to be closed, but it's flopping back open. When is the aortic valve supposed to be closed? During diastole. So a murmur of aortic regurgitation would be a diastolic murmur. You would hear this murmur in the aortic area during diastole. All right, coming down to mitral stenosis. Stenosis is when the valve is supposed to be open. When is the mitral valve supposed to be open? It is supposed to be open during diastole, when blood is flowing down from the atria to the ventricles. So a mitral stenosis murmur would be produced during diastole, so it's a diastolic murmur. You can trace mitral stenosis and mitral regurg back to things like rheumatic fever and rheumatic heart disease. But mitral stenosis, this is caused when that valve is just staying shut. It's stenotic, it's scarred, whatever, when it's supposed to be open. So this would be a diastolic murmur. Finally, mitral regurgitation. So regurgitation, again, the valve is supposed to be closed, but it's flopping back open. Okay, it's causing backflow of blood from the left atrium back up into, or from the left ventricle back up into the left atrium. So this valve is supposed to be closed during systole. So a mitral regurgitation murmur would be a systolic murmur. Okay, and that kind of wraps up basic heart sounds, the abnormal heart sounds, and murmurs. And remember, guys, that always using that bell of your stethoscope and listening at the apex for those, abnormal S3 and S4 sounds, that left lateral recumbent position. Remember that for your exams. Hopefully that you find this video helpful. Thank you, Greg, for helping us out today. And I just want to thank you guys for watching my video today.